sabay tayo yumapak sa landas ng medisina. Sabay nating hinarap ang pagsubok at paghirap, hanggang makamtan natin ang matinyas nating pangarap. Pagsikat ng liwanag sa unang araw ng Mayo, sa taon na tinadhana nilang ating sentenaryo, ay biglang natapos din 5 taon ng pagsisikap, 5 taon ng pagsasama sa oras ng saya't hirap. Tayo ang class ng 98, sa simula napakitang gilas sa loob ng PGH, may busilak ng utak at puso. Kailan may di nagkulang sa talino at talento. Tayo ang class ng 98, hanggang ngayon may pakitang gilas. Salamat PGH, mayaman sa utak at puso. Kailan may di nagkulang sa talino at talento. Ilang dekada pang tayo'y magkakasama, sabay-sabay tayo yumapak sa landas ng pagkakaisa. Sabay nating harapin tagumpay ng ating mithiin, karangalan at galing sa lahat ng ating gawain. Pagsikat ng liwanag sa bawat araw ng taon, pasalamatan natin Diyos na Panginoon, sa alaala't kwento natin ng katuwa at bighatin, sa lahat ng pangyayari na naghubog sa atin. Tayo ang class ng 98, sa simula napakitang gilas sa loob ng PGH, may busilak ng utak at puso. Kailan may di nagkulang sa talino at talento. Tayo ang class ng 98, hanggang ngayon may pakitang gilas. Salamat PGH, mayaman sa utak at puso. Kailan may di nagkulang sa talino at talento. Yung medisina.
Welcome to the UP College of Medicine Class of 1998 webinar series. As this year's Silver Jubilarians, our class is hosting most of the webinars this year on Mondays, Wednesdays, and Fridays, unless announced otherwise. Coming from our successful webinars last year, our 2023 theme is still Primary Healthcare in the Era of Universal Healthcare. In this current webinar series, we hope to unlock knowledge and discuss interesting and relevant topics for primary care physicians, including GPs, family and community medicine physicians, occupational and industrial health physicians, as well as other allied medical professionals. Here are some reminders for a smooth webinar experience. Firstly, kindly turn off your microphone and video for the duration of the webinar. Secondly, We encourage you to participate in an interactive discussion at the end of the speaker's presentation. Feel free to type in your questions in the Q&A chat box in Zoom or through the comment section if you are watching on Facebook. They will be addressed in the open forum after the lecture. Let us now begin with a short ecumenical prayer. Almighty Father, we praise and thank you for this day. We come to you asking for blessings and help for our speaker, moderator, and everyone present right now. We pray for your guidance as we unlock knowledge together. We ask that you show us how to conduct our work clearly and with a spirit of joy and enthusiasm. Protect us from the illness of apathy and hopelessness. Instead, keep the fire and love in our hearts as we work together with our colleagues. We ask that you challenge us to reach higher and further to be the best we can be for others. Amen.
Good afternoon to everyone on Zoom and to those watching the Facebook and UP Manila live streams. And to those in the US, happy Thanksgiving. Before we proceed, let me introduce myself. I'm Dr. Grace Jicaro Torres. I finished my dermatology residency at the Philippine General Hospital, and I also did my master's in public health and epidemiology at the University of California in Los Angeles. But most importantly, I am so grateful to be celebrating our Silver Jubilee this year, together with the rest of my classmates and dearest friends from the UPCM class of 1998. And I'm so looking forward to seeing everyone this December. Allow me to introduce our esteemed guest speaker, who has kindly agreed to lecture again this year. Dr. Eric Yasay is a clinical associate professor at the UP College of Medicine. He is an assistant training officer at the Division of Gastroenterology at the UP-PGH, and he is a member of the UPCM class of 2008. Today, he will walk us through dyspepsia. Welcome, Dr. Yasay.
Good afternoon, Dr. Grace. Hello, and thank you to the good afternoon to the participants, and thank you to the organizers of UP webinars and to class 1998 for again inviting me to share this about dyspepsia. So can I verify if the audience can see my screen?
Yeah. Yes, we can see your screen.
Okay, thank you so much. So again, hopefully after today's session, we will be able to cut out some of our notions about indigestion and be able to digest further this enigmatic symptom complex that we call dyspepsia. So I have some disclosures. I'm a speaker for several GI brands, particularly Mucosta, Ribamipide, the mucosal protecting agent, Pariet, the Reprazole, our proton pump inhibitor, and Normix, rifaximin. It's a gut-specific antibiotic. Okay, so for the objectives of today, we would like to improve the understanding of functional dyspepsia and its subtypes. We'd like also to introduce a simple approach to functional dyspepsia, emphasize the role of prokinetics as a treatment option for functional dyspepsia, and discuss the safety considerations and regulations on the use of over-the-counter prokinetics. So dyspepsia is a symptom complex referable to the epigastric area characterized by epigastric pain or burning, postprandial fullness, or early satiety. It is also commonly described as indigestion and in the vernacular may be pertained to as empacho or hindi natunawan. So remember that dyspepsia is a symptom complex and not yet a diagnosis, but very commonly dyspepsia is interchanged with functional dyspepsia, which is a diagnosis that is derived once organic causes of dyspepsia have been ruled out. Today, we would like to be able to digest this symptom for better understanding and management. So it's very prevalent with 20% of the population being having experienced dyspepsia at least once in their life. So I placed here a pictograph of how dyspepsia might be described by our patients. So since it's a very, very common functional GI disorder, or functional dyspepsia is a very common functional GI disorder, some of our patients will have difficulty relating their symptoms and would just present to the clinic with the chief complaint of pain or kirot. And sometimes, as a clinician, we are dumbfounded when a patient comes to you and says, Dok makirot or masakit, and then you are bewildered by the lack of description. So sometimes it really helps us facilitate the discussion if you are able to establish a good partnership and rapport for us to be able to fully understand what the patient is feeling. And there are many, many ways by which a patient can really explain epigastric pain. So it can be fullness, as seen here, like punong-puno or mabigat, like there's something that is nakadagan here in their epigastric area. It can also be early satiation or like having the sensation of a belt wrapped around the stomach. Some patients would describe it as parang kinukuryente or like this one, with it's like a lightning around the epigastric area. Parang pinapaso. There's some patients who say that's like bloating or nauseous. They parang nasusuka sila. Some patients would really have vomiting. And then, of course, heartburn and regurgitation are disease entities that are separate from dyspepsia altogether. So, being able to describe the symptoms thoroughly will give the physician better understanding on how to approach a patient with dyspepsia. And it also prevents the frustration of the patient being unable to relay symptoms. And being unable to relay symptoms is some of the root cause of the failure of treatment and repeated consultations. So we'd like to for you to be able to educate your patients on how to describe their symptoms very well so that you can manage their symptoms very well also. Of course, approximately 20% of patients with dyspepsia have an underlying organic disease. So in the initial approach to a patient with abdominal pain at the clinic, the first step is to really, really look for an organic cause of dyspepsia. And here are just some differentials for dyspepsia. So peptic ulcer disease, Helicobacter pylori gastritis, of course, reflux, biliary pain. A lot of our physicians would usually order ultrasound because, of course, some patients might confuse dyspepsia as pain that is coming from the biliary tract. Of course, pain that is caused by entrapment of the anterior cutaneous nerves can also be referred to as dyspepsia. Of course, you have to be wary about GI malignancies, motility disorders, pancreatitis, malabsorption symptoms, and you also have to elicit the use of medications because certain medications can predispose your patients to have dyspepsia. Increasing nowadays, especially because of our increased affluence and westernization of our diet, is of course the diagnosis of inflammatory bowel disease and decreasing in prevalence, intestinal parasitism. Then lastly, of course, we need to rule out systemic disorders and connective tissue diseases and vascular disorders that might explain the symptoms of the patients. So while 20% of patients with dyspepsia have an underlying organic disease, a greater majority or 80% will actually not have an underlying cause. So when a patient does not have an underlying organic or structural cause of the disease, we now pertain to the symptom as a diagnosis of functional dyspepsia, which refers to dyspepsia in the absence of relevant organic pathologies following investigation. So whether the patient would have undergone endoscopy and other tests that were relevant to work up his or her condition. So we follow the Rome 4 criteria in the diagnosis of functional dyspepsia. And according to this latest iteration of Rome, functional dyspepsia is defined by the absence of structural disease in patients experiencing bothersome. So it should be bothersome. So it should be something that really decreases their daily activities or function in patients and bothersome symptoms of postprandial fullness, early satiation, epigastric pain, or burning that has happened for the past 3 months with symptom onset of the last 6 months. And then we classify functional dyspepsia into two distinct subtypes with significant overlap. So sometimes authors would really classify functional dyspepsia into three. So the first one is postprandial distress syndrome, which is characterized by bothersome postprandial fullness or early satiation that occurs in at least 3 days in the past week. Of course, postprandial epigastric or burning sensation, epigastric bloating, excessive belching, and nausea can also be present. Vomiting automatically warrants the consideration of another disorder, and heartburn is not a dyspeptic symptom but may often coexist with patients with PDS. So symptoms are relieved by evacuation of feces or gas, should generally not be considered as part of dyspepsia, but rather irritable bowel syndrome or IBS. So the other subtype is epigastric pain syndrome and must include at least one of the following symptom at least once in a week. So it would be bothersome epigastric pain, severe enough to impact usual activities and or epigastric burning sensation. Again, this might include the overlaps. So the pain may be induced by ingestion of a meal, relieved by ingestion of a meal, or may occur during fasting. Okay, postprandial epigastric bloating, belching, and nausea can also be present. And then again, just like your PDS, persistent vomiting suggests another disorder, and heartburn is also not part of the criteria, but may coexist. Okay, the pain of the EPS should not fulfill the biliary pain, which is a dull pain or discomfort that is usually felt after meals in a decrescendo pattern that is located in the right upper quadrant and radiates to the right scapula. So again, as like in your PDS, symptoms that are relieved by evacuation of feces or platus should generally be not considered as dyspepsia rather than, but irritable bowel syndrome. So worldwide, patients very prevalent ang functional dyspepsia. It's higher in the Western countries and going to as high as 40% in the United States, but the global prevalence is 5 to 11%. In Asian countries, the prevalence is 5 to 30%. So it really causes a lower health-related quality of life. A lot of patients will have emotional distress. It's been correlated with anxiety and depression and leads to unintentional medical expenses, frustration, missed work, and time for school. So as I've said earlier, there's significant overlap between PDS and EPS in such a way that a lot of your patients with pure postprandial distress syndrome also may have sensations of epigastric pain and as vice versa. So a lot of your patients with epigastric pain syndrome may also have postprandial bloating. So in such a way that sometimes you have to treat first one and then see the response in a trial and error fashion. Okay, so what is the pathophysiology of functional dyspepsia? So the pathophysiology, just like any disease of the brain-gut axis, is not completely understood, but the theories are complex and they say that they are multifactorial. So they say that they are a conglomeration of physiological, genetic, environmental, and psychosocial factors that cause dyspepsia. But the most accepted theories include delayed gastric emptying and impaired gastric accommodation. So these are problems of motility in such a way that that's why some of the basis of the medications really would be to address these abnormalities in physiology. And then there's also hypersensitivity to the distension of the stomach. So visceral hypersensitivity is characterized by a lower threshold for induction of pain in the presence of normal gastric compliance. So they say that sometimes inflammation, inflammatory conditions, or a past infection can cause hypersensitivity. And then, of course, there's also an association of dyspepsia in patients with Helicobacter pylori infection in such a way that among patients with functional dyspepsia, treatment and eradication of Helicobacter pylori infection led to improvement of their symptoms. So pathophysiological mechanisms may differ between the two subgroups. So for postprandial distress syndrome, so there's gastric hypersensitivity, there's more salient delayed gastric emptying, anxiety, and an activated mucosal immune system, as opposed to the epigastric pain syndrome, where there is little evidence for abnormal GI motility and function. So at the onset, when you're really classifying your patient, you really would like to see whether they belong to PDS, because a lot of the PDS patients would respond well to your prokinetics as compared to your patients with BPS. Okay. And then, of course, as I said earlier, and this was just recently really recognized during the pandemic because a lot of us were really confined to our homes. Um, it really revisited, or the doctors really revisited the interaction between the gut and the brain, and the functional dyspepsia should now be really introduced as a disorder of the gut-brain interaction, together with a simple account that the gut-brain axis is a big part of how it impacts the diet, the stress, the cognitive behavior and emotional responses, and how these lead to symptoms. So the theory would say that mental stress
Excuse me,
causes.
Dr. Yasai, I'm sorry.
Yes,
Your audio is a little bit fuzzy. I was wondering
fuzzy.
if you could, yeah. So I'm
Okay,
wondering if
right.
there's something wrong with the microphone.
Sorry, I'll try to.
Is that better?
There, perfect.
Is that
Awesome.
better?
Thank you. Yes.
Yeah, this is better. Sorry. Okay,
Thank
I'm sorry
you.
about that. Okay, so so it really should be really introduced as a disorder of gut-brain interaction, and theories now say that mental stress causes increased activation of the amygdala and dysregulation of the hypothalamic pituitary adrenal axis, causing increased cortical levels. And when this happens, there is increased permeability of our gut, and this may lead to hypersensitivity and dysmotility. Okay, so now that we have a general idea of how functional dyspepsia arises and the targets that we can do, let's discuss a simplified approach to the management of functional dyspepsia. Okay, so for the initial evaluation of a patient coming to your clinic with dyspepsia, we have several goals, and one of it is really to exclude organic disease. So we have to differentiate heartburn, gallbladder pain, and pancreas pain, because of course these would entail a different pathway of workup altogether. Then you need to be able to elicit the use of medications such as those that can injure or decrease the mucoprotective mechanisms of our GI tract, such as your aspirin and your NSAIDs. And then, of course, you screen for systemic disease. So a lot of our dysmotility can come from a long-standing diabetes, for example. If there's also vasculitis, like in connective tissue disorders, that impede the flow of blood to your GI tract, that can also manifest as dyspepsia. And then, of course, another goal of the initial evaluation is to really identify red flags or alarm signs and symptoms. So these red flags or alarm signs are the impetus for immediate referral to secondary care or to a specialist care, particularly gastroenterologists, to be able to do endoscopy. So these include significant weight loss, which is defined as more than 5% decrease in the usual body weight for the past 6 to 12 months. Overt GI bleeding, which is melena or hematochezia, difficulty swallowing or painful swallowing, iron deficiency anemia that is unexplained, persistent vomiting, particularly postprandial vomiting, then of course palpable mass on the epigastric area, and a family history of upper GI cancer. All of these warrant immediate endoscopy. So in your first approach, again, I would really like to emphasize the establishment of an effective and empathic doctor-patient relationship and a shared understanding of what really is happening, especially for functional dyspepsia, because a lot of the times, functional dyspepsia will be a relapsing disorder, and your patient will really come back very frustrated and able to explain his situation. And it also becomes a source of frustration for the doctor because you're prescribing and your patient is not getting well. So you start with a good empathic doctor-patient relationship to be able to address that. Okay, we recently finished the Philippine Gastric Cancer CPG. It's still to be released, so I have internal access to this because I'm the technical advisor to the CPG. But urgent endoscopy is only warranted in patients at least 50 years of age with new onset dyspepsia, and among those with any alarm sign at any age. So for these patients, you really need to refer for urgent endoscopy. So non-urgent endoscopy might be considered in patients with refractory symptoms, and all patients with dyspepsia should be offered non-invasive testing for H. pylori using stool antigen test and urea breath test. So these also are going to be included in the Philippine Gastric Cancer CPG eventually. Then, of course, you need to refer your patients to gastroenterology when there is diagnostic doubt, increasing severity of symptoms, or if the symptoms of your patient are refractory to first-line treatment. So what are the first-line therapies for functional dyspepsia? So a lot of your patients would really ask you at the end, sometimes even at the beginning of your consultation, Doctor, anong pwede kong kainin or what can I eat? No, so there's really insufficient evidence to recommend dietary therapies in functional dyspepsia, unlike in IBS, where we even have a mnemonic for the FODMAPs, which are the fructose, oligodisaccharides. So some of the food that when broken down will lead to more carbon dioxide production. But for functional dyspepsia, this has not really been documented. So it may be more important to individualize treatment rather than, dictate something that is bawal to your patient that will lead to food aversion and eventually malnutrition. So what I usually just advise my patients is to really just track down the food and drinks that really give them symptoms. And then those are just the food and drinks that they will just avoid. Okay, and then of course, eradication for H. pylori is effective in resolving symptoms of functional dyspepsia. So it's still the standard triple therapy, which includes proton pump inhibitors, clarithromycin and amoxicillin, or for patients with allergy to penicillins, you can give metronidazole given concomitantly for 14 days. So part of the first-line treatment are also acid suppression therapy, particularly for EPS. So PPIs may be given for 4 to 8 weeks who initially test negative for H. pylori. And then you may also give your acid suppression to patients with persistent symptoms 4 weeks after the eradication of H. pylori, which are confirmed by stool antigen or urea breath test or upper endoscopy-based testing. So how about prokinetics? So as I've said earlier, these may be useful agents among patients with abnormal gastric motility, hypersensitivity to gastric distension, and impaired fundal accommodation, as is classically seen in postprandial distress syndrome. So the choice of prokinetics is dependent on the availability of the medication and its safety profile. And let's just take a look at some of the prokinetic drugs that are available. So prokinetics are used really to treat GI motility disorders, and they're very popular. So what I do sometimes is to give a patient trial of acid suppression, and then if they're not happy with it, I can give a prokinetic. So this can be cholinergic agonists, so which increase the levels of acetylcholine in the gap junction, and this facilitates stimulus of contraction of smooth muscles. Your acetylcholine inhibitors, acetylcholinesterase inhibitors, which again also increases the concentration of acetylcholine in the gap junction. Dopamine antagonists, serotonin antagonists, motilin agonists, the most common of which is erythromycin, which mimics the hormone motilin, and ghrelin. So the most common ones would be the ACH regulators, dopamine, and serotonin regulators. So nagkakatalo lang yan, of course, in terms of toxicity. So a lot of the medications would sometimes penetrate the blood-brain barrier. So these would be your dopamine and to some extent your metoclopramide. But metoclopramide, which both are dopamine receptor antagonists, are really very useful, particularly metoclopramide because it's peripherally acting. Domperidone particularly is a centrally acting dopamine antagonist, and it can facilitate a lot of extrapyramidal side effects. The other good prokinetics would be your peripheral acting agents, such as your serotonin receptor agonist, and of course your itopride, which is a dopamine receptor antagonist that does not penetrate the blood-brain barrier. So for the safety aspects, a lot of the first generation prokinetics, particularly cisapride, were removed from the market because of QT prolongation and arrhythmias. So cisapride was withdrawn from market, and there are now current restrictions for domperidone and metoclopramide, which limit its use for 1 to 2 weeks only, especially in the elderly when bradyarrhythmias are more common. Then, of course, extrapyramidal symptoms, especially among dopamine receptor blocking agents, particularly domperidone and metoclopramide, are also common. And then, of course, for your dopamine receptor antagonists, also they can induce the secretion of prolactin and stimulate breast milk production, and you don't want that. Okay. So there's a case control study that showed domperidone to be associated with the risk of sudden cardiac death because of the risk of QT prolongation in such a way that in 2014, the European Medicines Agency actually really just limited its use, not to extend for more than 1 week, and not to limit its use, not to use the domperidone among patients with nausea and vomiting, and to not give domperidone for patients with heartburn. Okay, so what's a safer choice? No, so a good choice for a prokinetic would be one that does not have extrapyramidal and the potential for cardiac toxicity. And the good choice is actually itopride because it binds to a different receptor and it decreases the drug-drug interaction, and it has not been shown to prolong the QT and can be given for a prolonged indefinite period of time. And this is just a meta-analysis of 9 RCTs that enrolled 2,620 functional dyspepsia patients that compared itopride with domperidone. And they used an assessment questionnaire. And in terms of global patient assessment, resolution of postprandial fullness and early satiation, it showed almost similar effects, if not better, than domperidone. Okay, so in terms of your prokinetic, then of course you would probably choose a prokinetic that is safer, something that does not cross the blood-brain barrier and decreases the cardiac side effects. How about your second-line treatment? And then the second-line treatment for functional dyspepsia include your gut-brain neuromodulators. So you have to be able to explain carefully the rationale for the use of these gut-brain neuromodulators. And they should also be counseled about their side effect profile. So these are the tricyclic antidepressants, and usually we give amitriptyline at 10 milligrams once daily and to titrate to a maximum of 30 to 50 milligrams once daily. You can also use antipsychotic sulpride and levosulpride at these doses. And then lastly, the third line. So when all of your first line and second line therapy have failed, you do behavioral therapy, or you refer your patient to a psychiatrist. So there are several ways by which functional dyspepsia is treated by psychiatrists. The first would be psychodynamic therapy, where they deliver a manual that focuses on the patient's interpersonal difficulties. So they list it in a diary, and they are explored, revealed, and the psychiatrists try to modify them to modify the response of the patient to these stressors. Cognitive behavioral therapy, I think this is yet to take root in the Philippines. It's to teach coping strategies. So I think this is really very difficult to do because you want to teach the patient a different response when they feel something. But these psychiatric management have been shown to be really useful among patients with functional dyspepsia. Okay, so this is just like a simple algorithm that I hope that you can use when you see a patient again in the clinic with dyspepsia. So for any patient with uninvestigated dyspepsia, your first goal is to really identify red flags. And if there are red flags, you need to refer to a gastroenterologist to perform upper GI endoscopy or other ancillary tests to really detect an organic disease. And if that organic disease is treated, then the patient can go back to primary care. Then at the initial consultation, if there are no red flags, you really need to detect also organic disease, like your systemic disorders, like your connective tissue disease, your diabetes. And if these are present, then you manage that, and that will lead to success, and then you can put back your patient to primary care. Then if there are no red flags and there are no organic disease, then you can now zero in on the diagnosis of functional dyspepsia. And of course, like what we said earlier, you have to establish communication, expectation setting that functional dyspepsia is a lifelong disorder with no cure, and that it's a chronically relapsing, and a lot of the treatments might be trial and error. Test and treat for H. pylori as necessary. And if you're successful, you can send back your patient to primary care. If that fails, then you can do a trial of acid suppression for 4 to 8 weeks as first-line treatment, depending on the symptom. If it's postprandial distress syndrome, then you can give a trial of prokinetics. And if you're successful, then the patient goes back to primary care. And if you fail that, you can do your second-line treatment. So your gut-brain agents like your tricyclic antidepressants and antipsychotic medications. You probably start thinking about psych referral at this point. If you're successful, then you can place your patient back to primary care. But if you fail again, then you really went to your last resort, which is psychiatric treatment. So this is hopefully a simplified approach, and this is based on the latest British Society of Gastroenterology guidelines on the management of functional dyspepsia. Okay, so what are the key points? Of course, functional dyspepsia is prevalent. The key to the diagnosis is the exclusion of organic diseases. Dyspepsia itself is just a symptom complex, so you need to rule out organic diseases to be able to zero in on functional dyspepsia. It's important to identify red flags or alarm signs so that you know when to send your patient off to secondary care. Management includes shared decision-making and a partnership anchored on good patient rapport and expectation setting. Medication choice is affected by symptomatology, with most patients only responding modestly to acid suppression. That's why usually we give them prokinetics such as itopride, which may be useful and safe among patients with postprandial distress syndrome. And with that, I think that's my last slide. And thank you to Abbott for sponsoring today's activity.
Thank you,
Thank
Dr. Yasai, for that enlightening presentation. As we begin our open forum, we would like to thank our sponsor, Abbott, for helping make this webinar possible. So we already have several questions here. One of them is, in a patient on prokinetics, and if the patient is already asymptomatic, so I'm assuming this patient is already getting better or has already recovered, do you abruptly stop treatment or do you titrate the dose of your prokinetic?
Okay, so unlike some medications like your histamine receptor antagonist, there is no tachyphylaxis or tolerance among these medications. So you can actually just abruptly stop them. And these are also, some of them are really over the counter. So you can, if your patient becomes symptomatic again, then they can just procure it again. So yeah, you can give them sporadically.
Okay. So, when you say, so now, thank you for enlightening us about functional dyspepsia. And it seems like there's so many things and so many differential diagnoses to consider. And could you say that it's pretty much like a diagnosis of exclusion almost? Yes.
I think, Doc Grace, it's really like a diagnosis of exclusion because you really need to rule out organic causes like peptic ulceration, particularly the malignancies. Because of course, when a patient has a malignancy, the management is really different. And I would agree that it's really a diagnosis of exclusion because it's really tweaking how your brain interprets things. And that's really very difficult to do.
It seems like a very simple disease, but there are so many things to consider. So it's pretty much very difficult to diagnose also. And I noticed that anxiety could be a cause of your functional dyspepsia. And so do you see a lot of, among your patients, do you see a lot of young adults or adolescents, or even in your like teens or early 20s in your practice?
Yes, Doc. Actually, this is really a disease of the younger ones. So, especially during the pandemic, I would get patients who are really very anxious because they could not go out. We call it, I think the situation became because they couldn't do anything and they were confined to their homes.
Mhm.
The hypervigilance, we call it hypervigilance. So they were
Okay.
really observing their body. So
Mhm.
some patients, binibilang nila yung utot. Some patients, they count their burp, no?
Oh my God.
So,
Okay.
and they're very, they interpret as if, like, for example, a patient would come to me, Doc, I got 10 burps today. And then it's
Mm.
really like, it comes to me as a surprise that why are you counting your burps?
Yeah.
Why are you counting your farting? So it's really, I think, part of what they grew up into because they were confined into their homes. Because I feel that in our generation, we didn't have that because we were able to play in the streets or something like that. So it's really something that really is brought about by hypervigilance, not understanding their symptoms. So it really falls into our hands to explain to our patient that some like burping is a physiologic process and doesn't really necessarily represent an illness as well as farting or something like that. So
Absolutely.
that's very important to address.
I have one question here. I don't see it anymore, but earlier it said the one who asked the question said that he or she is seeing a lot more functional dyspepsia patients among adolescent patients. So is the management the same pretty much with adolescent patients?
I think it would really depend. I'm not a pediatrician, so maybe you should not quote me about this, but maybe that really depends on the age of the patient. So
Okay.
the pediatricians would say that the children are not small adults, right? But maybe the adolescents might be already have developed organ systems that might assume the bodies of adults. So I would say that probably the approach might be similar in patients who are adolescents already or nearing the adult age. Yes.
Okay. Is it right to put in the diagnosis dyspepsia ulcer-like or dyspepsia dysmotility-like?
Yeah, I think that's one way of putting it. No, so it's really telling us, but dyspepsia really is a symptom. So when you say dyspepsia, it's really the symptom also of peptic ulcer, for example. So maybe just put their dyspepsia considerations, ulcer or gastritis from H. pylori or medication induced and then after the workup, you can put functional dyspepsia.
Okay. Do probiotics help alleviate symptoms? There's so many kinds of probiotics. So and a lot of people are using it. So does it?
Yeah.
Is there a difference between S. boulardii or B. clauselii?
Yeah.
I'm not sure.
So yeah. So okay lang doc. I was able to read it. So it's a good
Okay.
question because probiotics is also like it's been a decade now or even more than a decade now that probiotics is like the flavor of the decade. So we use probiotics left and right, but there's some evidence for it because of the use of antibiotics or sometimes the dysbiosis that ensues after an infection can cause symptoms. So this is more apparent actually in post-infectious IBS. For example, if you had a bout of acute diarrhea, sometimes even after the bout of acute diarrhea, you have a prolonged irritable bowel syndrome-like symptoms. The difference between S. boulardii, Saccharomyces boulardii is a fungus. Between Bacillus is a bacterium. So sometimes we use S. boulardii if a patient is on antibiotics because it's resistant to the usual antibiotics like your penicillin or the ones that kill your bacteria. So I personally sometimes give probiotics among patients with post-infectious IBS and among patients with antibiotic-associated diarrhea because there's some improvement in their symptoms. For functional dyspepsia, it's dysbiosis is part of the theories for for functional dyspepsia, but the evidence is not so robust as we would see in prokinetic and acid suppression and treatment for H. pylori. So like I said earlier, it's really communicating with your patient that in the management of functional dyspepsia, it's like a trial and error. So what might work for one patient might not work for another. And you have to really ask your patient, is the probiotic doing its job? If it's not, then you shift to another. Yeah.
I'm sure it can be frustrating both for the doctor and for the patient, because you don't know
Yes.
how long you'll be managing this patient, or maybe you have a lot of patients that you see forever.
Yes,
What
yes,
do you
yes.
think is the most challenging part in managing functional dyspepsia?
I think still the communication. Like for me, I'm a gastroenterologist. I'm more used to the organic ones, right? So I'd like to see gastritis. I'd like to see an ulcer. I can manage a mass, because, those are things that are tangible. But for functional dyspepsia, you don't really see it. Like you don't understand what it is. But I think I cannot overemphasize really the importance of communication. So I really started with the pictographs because sometimes the frustration starts with the chief complaint. It's really the patient coming in, Doc, makirot. And then, what's makirot? The kirot of like pinch is different from the kirot of hilab. Like, the cramps is different from a burning sensation, is different from a heartburn, is different from biliary pain. So we begin with that, and I really, really, really describe that as the most important part of the consultation, to really describe, because we get unlimited abdominal ultrasounds, for example, like, when I see a patient, Doc, I came here because of an ultrasound result. And then I would usually ask, why was an ultrasound requested? And then the patient doesn't know about it, because it's really like an instinct among Filipino doctors that for any abdominal pain, they order an ultrasound. Well, it's part of ruling out organic causes. But if you're really thinking of a biliary pain, for example, then that's a time to order a hepatobiliary tree ultrasound. So I think there's really excessive or overuse of hepatobiliary tree ultrasound, even for patients with non-classic biliary pain. Like, but that's what I mean. And the difficulty really is establishing the communication, how to relay the pain that the patient is having, and making the doctor understand that pain and localizing it in the GI tract.
Okay. All right. That's well said. What medication is safe to be given to a patient with concomitant functional dyspepsia?
Who is pregnant? Yeah. So for pregnancy, it's really the antacids or the acid neutralizers. So those are the the safer medications for pregnant patients. Itopride or the prokinetics have not been proven, or there's still lack of data for safety for pregnant patients. So for pregnant patients, you stick to the antacids like your Cremeles, your Gaviscon, because they are topical, so they are not absorbed, and they probably will not give systemic effects. The next would be to give your PPIs, because the PPIs have been shown to be safe, particularly pantoprazole, esomeprazole are class B, are category B. Omeprazole is category C, but the perinatologists like it because it's the oldest PPI and it has very robust data that it doesn't cause fetal compromise. So you can still give omeprazole to your patients who are pregnant.
Okay. Hold on. Can a person have different foods to avoid for a functional dyspepsia? Yeah, that's a question.
Yeah. So again, sometimes I really tell even the patients not to be food averse. So we are now advocates of individualized management, and instead of really strictly adhering to a certain diet, I just tell my patients to really make your own list of food triggers. So it's a food and drink checklist that if that particular food causes them symptoms, then that's the only time they put it in the list and avoid them. But otherwise, I don't like to adhere to a certain diet because there's no study that says that a certain food causes functional dyspepsia. It just leads to food aversion and malnutrition. So you just tell your patient, you can eat anything, but as long as you feel that there's pain, you put that kind of food in your list and avoid it.
Okay. Does caffeine play a part in causing symptoms of functional dyspepsia? Or how much caffeine probably would be a better question.
Yeah, but like me, I have very bad epigastric pain, but I like coffee. So it's really, weighing between your quality of life and your symptoms. So again, as I've said, there's no particular food or drink that has been shown to be associated with functional dyspepsia. So if you can't wake up without coffee, then do it. It's really just weighing between drinking your coffee or suffering from the pain. So if it's more acceptable for you to suffer a little with the pain, then you can drink your coffee.
I think that's where you're, what they say, everything in moderation. I think that's,
yes.
You apply that. So what can you recommend for a patient with GI cancer stage 1 that developed dyspepsia?
Oh, so if there's already GI cancer, is this gastric cancer? Then if it's stage 1, then of course, resection is the key to success, of course. So if it's gastric cancer stage 1, you can choose between endoscopic therapy or a radical surgical resection. And that's very important to really attain cure for patients with gastric cancer.
When is rifaximin prescribed? Do you use that to treat? Can you use that to treat functional dyspepsia?
Yeah, so the indication of rifaximin is very wide, actually. So it's a gut-specific antibiotic. So we usually commonly use rifaximin for patients with hepatic encephalopathy. So that's the best evidence for that. You can also sometimes use it for diverticulitis or inflammatory conditions of the intestines. But for functional dyspepsia, if you want to tweak the dysbiosis. So relying on rifaximin really is banked on the pathophysiology of dysbiosis as the cause of functional dyspepsia. And then again, we've enumerated the first line, which is your acid suppression, H. pylori treatment, and prokinetics. If that doesn't work, if you think that the functional dyspepsia of your patient is really from a dysbiosis or coming from a previous infection or the use of antibiotics probably, then you can do a trial of rifaximin.
Okay. Okay. So this one, is there a role of stress and depression in functional dyspepsia?
Yeah. So I think, it's really, it has really been associated. Stress and depression has been associated with functional dyspepsia. And having stress and depression has also been associated to the development of functional dyspepsia, and really emphasizes the role of the gut-brain interaction. And it's really very inculcated in our language also. That's why we have, I feel butterflies in our stomach, diba? So ano pa ba? So malayo yan sa bituka. So it's really also in our language how our brain interacts with the GI tract. So I think, that's why a lot of the interventions would really escalate. If your treatment is not moving, you need to escalate and end up with a psychiatrist trying to help you manage your patients.
Okay, so related to that, and you mentioned earlier that tricyclic antidepressants or low-dose TCAs can actually help with functional dyspepsia. Do you, as a GI specialist, or do primary physicians, can they treat the patients directly with TCAs, or do they need to refer the patient to a psychiatrist first?
So personally, I do refer. So
okay.
I don't, it's not part of my practice to prescribe tricyclic antidepressants. So sometimes after failure of therapy, of several trials of medications, and then I would start easing in my patient to the concept of seeing psychiatrist to help us with the management. And if you establish good rapport early on, he or she will understand that eventually, if they are not responding to the usual medications, that they would need to really try to tweak how they think about what they feel. And they're open to it, a lot of my patients.
Okay. Does eating gas forming foods like potatoes, soda, or do these aggravate the symptoms?
Yeah, so some of these gas forming foods, so like the FODMAP, so that's our mnemonic. So fructose, so those are your sodas, oligosaccharides, disaccharides, mono and polyols. So these are when they are digested, we release carbon dioxide as the byproduct. So these might actually exacerbate your symptoms, but these have been better documented in IBS. That's why in IBS, FODMAPs or avoiding FODMAPs as a food source and drink source is part of the management of IBS.
Okay. I have another question here. She said, I have observed American and European patients when on antibiotics, most especially Coamox, are prescribed probiotics. Any comment on this?
Yeah, so that's very common. So we discussed it earlier. Antibiotic-associated diarrhea and Comox is one of the more common antibiotics that are prescribed. And I think Coamox is also very common cause of pseudomembranous colitis. So a lot of GIs or a lot of infectious disease specialists are really afraid of Coamox. If you're going to give a probiotic concomitantly with Coamox, then maybe you should give Saccharomyces boulardii because that would be resistant to the Coamox. Because if you just give a normal like Bacillus, then it would die with the Coamox.
Okay. Is functional dyspepsia a criterion for EGD?
Well, if you have alarm symptoms, then you send your patient for an EGD. If your patient has been on months-long treatment without response or refractory dyspepsia, and you have to think of another cause, then you send your patient for EGD. So again, you need to exclude an organic cause. If your patient has heartburn, then you need to document if the patient has heartburn. If there are any alarm symptoms, then you send your patients right away for EGD. But functional dyspepsia per se is not an indication for EGD.
Okay. Are there home remedies that can be used immediately if there's no immediate available medications for dyspepsia or if there's pain?
Yeah, well, that's really also part of the trial and error. So some of the patients would put in hot compresses. Some of patients would really try to induce vomiting because, of course, the postprandial distress syndrome needs to extrude some of the pressure. So these are some ways of some of our patients relieve themselves. But otherwise, of course, the usual home remedies would be your antacids if you don't have a PPI. And then, of course, the over-the-counter prokinetics can also be used sporadically, but very, very short period of time because of the issues of safety.
Okay. Do you refer to cardiologists also for patients with functional dyspepsia?
Personally, I don't, but I look at the ECG. If I see changes and then I'm planning to start the patient on a prokinetic that has a cardiac complication, then I might refer the patient. Usually see these among patients who are elderly with blocks in their ECGs, but otherwise, we can manage them on our own. And a lot of the functional dyspepsia patients are the younger ones, because they are the ones with, colorful imagination, a lot of things in their mind, very anxious about what they have accomplished. The elderly will have a lot of organic diseases, but the younger ones, they're the ones that have a lot of, things in their mind still.
So communication talaga is the key when you treat patients with functional dyspepsia. Mahirap,
Yes, yes.
mahirap na sakit ito.
Mahirap. And you both ends, the receiving end and the treating end,
Mhm.
both are really frustrated, especially when your patient comes back again,
Mhm.
successful for a while and then nandito na naman.
Yeah.
Some patients may nakain lang na isa, babalik na ulit and then
Mhm.
yeah, so it's really very frustrating. So patience is the key. What I tell my patients is that's why we call you a patient because you're patient.
Okay. Okay. Can we give tramadol to a patient who came to the ER IV, tramadol IV for patients with intolerable pain, once organic pathology is ruled out?
Yeah, I think tramadol is a good choice of medication because a weak opioid can also, really affect, the GI tract and can it give you euphoria a little. So I like tramadol because it's a very weak opioid and
Mhm.
it can relieve a lot of the GI symptoms without really paralyzing your GI tract because you don't want to paralyze your GI tract. So a lot yung mga cocktails dyan, di ba, when you go to the ER, some of the doctors would give you metoclopramide with Buscopan. And it's really just negating each other because you gave a prokinetic and you gave an antispasmodic and then you paralyze the intestines as an end result. So I would rather choose something that doesn't affect the motility of the GI tract like tramadol to relieve the pain. Because a lot of opioid receptors are also in the GI tract. And when you give tramadol, it gives you pain relief.
I see. Well, we still have some questions, but this is such an interesting topic, but we are almost out of time. So, Dr. Yasai, thank you so much for taking time out of your busy schedule. We really appreciate your expertise on this topic, and we present you with a certificate of appreciation. So, thank you so very much. And if our speaker has some time and energy to spare, we invite him to type answers to the remaining questions in the Q&A box.
Okay, thank you, Doc. Thank you.
Thank you, Dr. Yasai. Class 1998 would also like to thank those who helped this webinar make this webinar possible: the University of the Philippines Manila College of Medicine, the UP Medical Alumni Society, the Postgraduate Institute of Medicine, the UP Information Management Service, and our sponsor for this webinar, Abbott. Our next webinar is about the so-called fourth trimester or life with a newborn. Our expert speakers are our classmates, Dr. Resty Bautista, our Associate Professor at the UP College of Medicine and Chief of the Division of Newborn Medicine in PGH, and Dr. Rosibel Candido Esguerra, Clinical Associate Professor of the Section of Reproductive Medicine, also at PGH. This webinar will be held on November 27th, Monday, also at 12 noon. You can use the same Zoom link to register in advance or use the QR code shown here. Our class is also inviting everyone to the annual UP Medical Alumni Society Golf Tournament on December 11th at the Ayala Greenfield Golf and Leisure Club. This exciting golf event will include lunch, giveaways, and a raffle, among other things, among other highlights. Interested players may register by scanning this QR code or typing bit.ly/upmasgolf in your browser. To receive your attendance certificate, kindly answer the evaluation form, which you can access through this QR code. We will also post the URL in the chat box below. You will be able to receive your attendance certificate only after answering the evaluation form. Please ensure that the name you enter in the form is the name format that you want to appear in your certificate. See you next time as we continue to unlock knowledge for primary care workers and allied medical professionals. Stay safe, everyone. Thank you.